Hello, my name is Andrew Scarborough, and this presentation forms part of my assessment for the Health Informatics module of the PG Cert in Clinical Bioinformatics at the University of Manchester. I will be discussing the patient pathway of neurofibromatosis, using a typical example patient scenario. I will be using visual aids, including swim lane diagrams. I will then critique specific aspects of the pathway to suggest room for improved efficiency and function. The piece of work I'm presenting to you is a collaborative effort where I must thank my fellow students Jeff, Dave, Yantat, and Emma. We began the project with a brainstorming session. It was I who brought up the idea of focusing on Neurofibromatosis Type 1 because I have a strong background in neurological disease. I brought up the fact that this would be a good condition to focus on for two primary reasons. One, because neurofibromatosis arises from a genetic mutation, and two, being that there are multiple points of contact in the patient pathway. NF1 is the most common form of the disease, which explains the rationale for specifying this. On consensus, we agreed that it was a suitable condition to study due to the fact it is a genetic disease and is multifaceted in terms of how it manifests itself over time, where many departments become involved in the patient pathway from a pediatric patient at its genesis right through the lifespan. Neurofibromatosis has a very variable phenotype, affecting many physiological systems. Now let's reveal some background of this disease. Neurofibromatosis is a genetic condition and is non-discriminatory. It affects everyone equally regardless of ethnic background and gender. We will be looking at neurofibromatosis type 1, which is the most common form. It can be characterized by multiple benign cutaneous neurofibromas and or café au lait macules, which can present as seen in the images on the right-hand side. These macules appear as coffee-colored spots, and it generally requires more than one to suspect NF1. A host of additional features can support a more definitive diagnosis, including the following. NF1 is an autosomal dominant disease that is triggered by mutations in the neurofibromin 1 gene. The NF1 gene is found on chromosome 17 and codes for a protein called neurofibromin, a tumor suppressor protein. The incidence of the disease is estimated at 35 to 40 in every 100,000 people. If a mutated allele is inherited, the disease is triggered according to the principle of the second hit. There is occurrence of a second pathogenic mutation on the normal allele. 50% of NF1 cases are due to new mutations. Affected parents have a 50% chance of passing the disease on to their children. The NF1 gene spans approximately 400,000 base pairs. The NF1 protein shows sequence homologies with the GTPase activating protein, GAP. Defective GAPs are not able to switch off mitogenic signals. Thus, cells proliferate in an uncontrolled manner. In a typical patient scenario, the first signs of NF1 are often café au lait spots, which are apparent in the first few years of life or at birth. A clinical criterion must be at least 6 café au lait spots. Axillary and inguinal freckling usually occurs between the 3rd and 5th centuries of the patient's expected life cycle. The patient will be expected to develop neurofibromas. Neurofibromas are benign Schwann cell tumors that are classified according to location. These tumors can be focal or diffuse cutaneous, nodular or diffuse plexiform, and spinal. Lisch nodules are apparent in over 80% of NF1 patients. These are characterized as small, rounded, sharply demarcated, and slightly raised changes in the iris, with light yellowish-brownish tones. The patient may also be prone to developing optic nerve gliomas, and also other intracranial malignant NF1-associated tumors. Effects on osseous tissue are also common. Bone malformations caused by mutations in the NF1 gene cause short stature, scoliosis, asymmetry of the head, and tibial osteoarthritis. Surgical interventions are necessary in the case of pathological fractures or habitual dislocations. Life expectancy of the disease is typically around 60 years of age. The autosomal dominant inherited neurofibromatosis type 1 has an incidence of 1 in 2,000 up to 1 in 4,000 births, and it is the most common neurocutaneous syndrome in all ethnic groups, as well as being one of the most common hereditary diseases. Worldwide, it affects around 2 to 3 million individuals. As you can see, NF2 is comparatively much rarer. The patient pathway for NF1 is rather large due to the multiple clinical manifestations of the disease that need to be monitored and treated over the course of the lifespan for these patients. As such, we broke down the pathway into sections, and I was tasked with looking at the imaging department and how data flows to and from multiple departments, utilizing a number of different physicians, databases, and programs. A causal therapy for NF1 is currently not yet possible, but neurofibromas and tumors can be surgically removed or irradiated after a careful risk-benefit assessment. Severe neurological or orthopedic symptoms are also monitored. I have worked in a neurosciences outpatients department at the John Radcliffe Hospital, which included specialized services for NF1 patients. This reduces bottlenecks and addresses unique symptoms. It allows for time and space exclusive to this group of patients, improving efficacy of delivery of services that can spill into other areas and departments. Neurologists in this space will specialize in neurofibromatosis and will collaborate with multiple other departments and actors in the patient pathway. Here is our swim lane diagram for a typical NF1 patient scenario. You will see my section below with relevance to the imaging department. It is crucial to note that children with NF1 are at risk of developing low-grade gliomas of the optic pathway and brainstem. Optic gliomas can be detected by CT scan or more sensitively by MRI. In the swim lane diagram, we can see how information flows through the imaging department via various neuroradiology systems. This includes DICOM for imaging and MRI examination requests via the ORM. This takes the form of EPHI and PACS. ORM is a type of messaging conforming to HL7 standards and supplies information about the request. Electronic personal health information is exchanged along with the picture archiving and communication system. PACS handles the storage, recovery, and display of radiologic images of all types used in this scenario. To improve the pathway, we must consider the current guidelines for diagnosis and management of the condition. As has been mentioned, loss of neurofibromin through mutation leads to an increased risk of developing benign and malignant tumors which require monitoring. This includes hyperintense lesions on T2-weighted brain MRI. You can see the degree of risk of these occurrences of these manifestations at different age ranges. My initial thinking was to improve monitoring when patients visit the A&E department once there is a problem that requires immediate attention. I found this somewhat odd because epilepsy, hydrocephalus, and cognitive deficits, which are known effects of this type of progression that we can see, can be highlighted before it becomes more serious. I understand that it's looking at likelihood of risk v benefit, and optic glioma is more likely, but I feel this is still very important. Another thing I would improve with the NHS is to introduce a health passport, which has been recommended in Germany to limit use of gadolinium-based contrast agents in order to prevent potential toxicity from retention. This can accumulate over the course of time when patients are constantly being monitored. My other more general thought was to actually increase monitoring with MRI scans, but it's not recommended because the guidelines don't recommend it. Therefore, we must look at alternatives to monitor patients outside of the hospital. A key measure here is blood pressure. I mentioned an alternative option for assessing worsening of the condition, and Jeff brought up a good point about blood pressure. The mainstay of managing NF1 in general is age-specific monitoring of these disease manifestations with patient education and self-monitoring. I would suggest that patients could use an app for monitoring blood pressure that links with the patient access online data. This would then send a warning when blood pressure is consistently too high over the course of a month. An appointment can be offered to the patient for further investigation. It's a real possibility at all ages that severe disease complications such as malignant peripheral nerve sheath tumors will become symptomatic in between appointments. So this intervention provides us with one method of keeping track of the patient's condition worsening. Currently, the minimum requirement for an asymptomatic adult is to have an annual blood pressure measurement. We will be looking for the figures highlighted here, and if the blood pressure is found to be too high during a clinic visit, it should be checked 3 times in 1 month to verify these findings. Some adults are happy to monitor their own blood pressure, and that's my recommendation, using portable machines at home, which could be done in conjunction with the proposed app. Jeff has mentioned that this type of monitoring could also be useful for identifying clinical presentation of pheochromocytoma, hypertension being a key characteristic of this. It occurs at this percentage, so it's quite small, and about 12% of these tumors are malignant. Monitoring can be a useful tool for assessing necessity for treatment overall, not just specific to this type of tumor, and treatment involves alpha and beta blockades. This could easily be synced to the electronic patient record, and the information could go to each clinician involved with the care of these patients. Those are my key suggestions for improvement in the pathway, and here are my references.